Hello, everyone, and welcome to our module on endometrial cancer. Let's start by talking about a leiomyoma, which is commonly called a uterine fibroid. Fibroids are benign tumors of the myometrial layer, the smooth muscle layer of the uterus. Most women who develop a fibroid have more than one. There are often multiple tumors, as shown in this picture of a woman whose uterus has multiple fibroids present. These typically occur in premenopausal women, and that's because their growth is stimulated by estrogen, and for this reason they usually resolve at menopause when women have less estrogen present. The histologic appearance of uterine fibroids is very straightforward. These tumors show smooth muscle cell proliferation on biopsy, just like in this picture shown on the screen here. Usually these tumors are asymptomatic and detected as a pelvic mass on physical exam. They can be visualized with ultrasound, and in some cases they cause symptoms like irregular bleeding. Some women who have fibroids have heavier, longer menstrual flow. They can cause infertility. You can imagine that it's hard for an embryo to implant in the uterus when a fibroid is present, and then finally they sometimes cause pelvic pain. Now, uterine fibroids are relatively common and they are benign tumors, but there is a malignant smooth muscle tumor of the uterus called a leiomyosarcoma, which is much more rare compared with fibroids. This is a malignant tumor, and importantly, it arises de novo, not from fibroids. So fibroids are not a pre-malignant tumor of a leiomyosarcoma. The leiomyosarcoma tumors arise de novo. In addition, there are a couple of other key distinctions between this malignant smooth muscle tumor and fibroids. Leiomyosarcoma occur in postmenopausal women, not premenopausal women like fibroids. And leiomyosarcomas are usually a single large mass as opposed to fibroids, where women often have multiple masses in their uterus. Next, let's talk about endometrial hyperplasia, which is a very important pre-malignant condition of the uterus. Endometrial hyperplasia occurs when there's stimulation of the endometrium by unopposed estrogen. And what I mean by unopposed estrogen is estrogen that is unopposed by progesterone. So in endometrial hyperplasia, there's an absence of progesterone stimulation and withdrawal as normally occurs in the menstrual cycle. So basically, in the first half of the menstrual cycle, the endometrium is supposed to undergo hyperplasia and grow in size. But it's supposed to stop in the second half of the menstrual cycle because progesterone opposes estrogen, and then it's supposed to be followed by menstruation. If the progesterone and menstruation parts don't occur, then the endometrial lining just keeps growing in size, and that's called endometrial hyperplasia. And this often occurs in peri or postmenopausal women because in these women, menstruation has slowed or stopped. In addition, they are anovulatory because they have no more eggs left in their ovaries, so there's no progesterone coming from the ovaries. And therefore, in this situation, any estrogen source leads to unopposed growth, and that leads to hyperplasia. Besides menopause, there are other risk factors for endometrial hyperplasia, and I've listed some of them on the screen here. And it's easy to understand all of these risk factors because in each one of them, there is some source of estrogen that drives growth of the endometrium. So, for example, obese women have an increased conversion of androgens to estrogens by their fatty tissue, especially the estrogen estrone. So this can drive endometrial hyperplasia. Women with polycystic ovarian syndrome or PCOS are first of all usually obese, so they have the same problems as obese women. In addition, they do not ovulate, so the opposition of estrogen by progesterone may not occur. Tamoxifen is a drug used to treat some forms of breast cancer, but it functions in the uterus as an estrogen agonist, and this can cause hyperplasia. Women who have marked menopausal symptoms sometimes take hormone replacement therapy to relieve the symptoms, and some of these therapies are estrogen-only therapies, and that can cause endometrial hyperplasia. And then finally, there are some ovarian tumors that secrete estrogen. These are called granulosa cell tumors, and women who develop these tumors often present with uterine findings like uterine bleeding from hyperplasia and also the presence of an adnexal mass. The main clinical feature of endometrial hyperplasia is abnormal uterine bleeding, and what's important to know is that this is the same presentation as endometrial cancer, which we'll talk about shortly. And in fact, endometrial hyperplasia has the same risk factors as endometrial carcinoma. Endometrial hyperplasia is a pre-malignant condition that often leads to endometrial cancer. So what this means is when a woman presents with abnormal uterine bleeding, you don't know whether she has hyperplasia or a uterine cancer. So the key diagnostic test is an endometrial biopsy. And what it will show when the woman has endometrial hyperplasia is the presence of abundant crowded endometrial glands. Shown on the screen is a biopsy specimen of normal uterine tissue on the left and of endometrial hyperplasia on the right. And you can see that the picture on the right just has more uterine glands and they are crowded together. As I said before, endometrial hyperplasia is a pre-malignant condition. Women with hyperplasia are at increased risk for endometrial carcinoma. And when an endometrial biopsy is done and hyperplasia is identified, the hyperplasia can be graded based on the histology by a pathologist. The hyperplasia may be either simple or complex, and it may or may not contain the presence of atypical cells. And you should be aware that complex histology with atypical cells places women at the highest risk of progression to endometrial carcinoma. So how do you treat endometrial hyperplasia? Well, for women with low-risk forms, you can treat the hyperplasia with progestins. And this is just basic endometrial biology here. Progestins are synthetic versions of progesterone. So just like progesterone, these drugs oppose estrogen effects, and they can reverse the hyperplasia, and in many women, they improve the bleeding. Now, if women have a high-risk form that is a high risk of transformation into carcinoma, then hysterectomy is usually recommended so that the woman doesn't go on to develop cancer. So now let's talk about endometrial carcinoma. This is the most common gynecologic cancer, and it usually occurs in postmenopausal women. The average age at diagnosis is about 60 years old. And this is easy to understand if you remember what I said before, that at menopause, women stop ovulating. And when they undergo anovulation, their ovaries stop producing progesterone. This leads to more estrogen exposure of the uterus, and that can lead to endometrial carcinoma. And the classic presentation is abnormal uterine bleeding, just like we talked about before for endometrial hyperplasia. Some other features of endometrial carcinoma are shown on this slide. Many of these I mentioned earlier. The diagnosis is by endometrial biopsy. Carcinoma is often preceded by endometrial hyperplasia, and it's driven by unopposed estrogen. And all the risk factors we talked about earlier for endometrial hyperplasia are also risk factors for endometrial carcinoma. Things like obesity, polycystic ovarian syndrome, tamoxifen, and so on. Endometrial cancer is usually detected early because of the bleeding that occurs, and it's often treated with a total abdominal hysterectomy to take away any endometrial tissue that could potentially be cancerous. In terms of pathophysiology, there are a couple of subtypes of endometrial carcinoma you should be familiar with. They each form a little bit differently, so the two subtypes are classified histologically, and the major subtypes are the endometrioid type, which is the most common type, and serous. The endometrioid subtype, which is called type 1, is estrogen-dependent hyperplasia leading to carcinoma, just like we've been talking about in this video. The second subtype is less common. It's called the serous subtype, or type 2, and this type is special in that it's estrogen-independent. The endometrioid subtype is the most common type. This is what most women with uterine cancer have. This subtype is caused by estrogen-dependent hyperplasia, just like we've been discussing all along in this video. The risk factors are anything that causes more estrogen stimulation of the endometrium leads to more risk, just like obesity and all the other things we talked about earlier. And the reason this subtype is called endometrioid is because it resembles endometrium. This is a picture of the endometrioid subtype on the screen here. You can see that it has structures that resemble the glands of the endometrium. The second subtype of endometrial carcinoma, the more rare subtype, is called the serous subtype. And the key thing to know about these endometrial cancers is that they are estrogen independent. They are not caused by estrogen stimulation of the endometrium. Under the microscope, the key characteristic is the presence of pink serous material. That's why they're called the serous subtype. This is an example of one shown on the screen here. And these tumors arise from atrophic endometrium postmenopause. They tend to occur in women who are a little bit older than the women who get the endometrioid subtype, and their endometrium has become atrophic, and that leads to this type of endometrial cancer. The key thing to know about this subtype for your boards is that the most frequently altered gene found in this type of endometrial cancer is the p53 tumor suppressor gene. It is abnormal in 90% of these tumors. Compared to the endometrioid subtype, the serous subtype has a poor prognosis. These tend to be more aggressive endometrial cancers. I'll finish this video with this slide on hereditary non-polyposis colorectal cancer, or HNPCC. It's also called Lynch syndrome. This is a genetic disorder that runs in families caused by germline mutations in DNA mismatch repair genes, and I discuss it in more detail in the video on colon cancer in the GI section. And the reason I discuss it there is because in this disorder, patients have colon cancer that runs in their family. But what I want to point out is that in addition to colon cancer, families with HNPCC are also at increased risk for endometrial cancer among female members. In fact, among females with HNPCC, endometrial cancer is the most common non-colon malignancy. The risk for women with Lynch syndrome is up to 70% compared to 3% in the general population. So a high-yield fact for you to remember about HNPCC is that it's not just a colon cancer syndrome. And that concludes our video on endometrial cancer.